So continuing from the theme yesterday and also from a number of speakers, the aim of rehabilitation, particularly which is my field, is to look at the patient as a whole, to look at not just the diagnosis, not look at just the kind of syndromes or the causation of the problem, but as physiatrists or rehabilitation physicians, we look at the whole picture and what are the future things for that particular patient, or we like to call goals. So in addition to contribution from myself, there are three of my colleagues. Dr. Jose is a pediatrician with special interest in disability management. Dr. Mehta is a pediatric neurologist, and Dr. Lorna Hyde is a pediatric rehabilitation specialist. So we designed this pediatric transition clinic, and transition means pediatric patients who are between the age of 17 to 19. So they're going from 17 to 18. In the NHS in the UK, 18 is adult. And some people say 16 to 18 is transition. And in the health service, you become a patient under adult clinician when you are 18. And the reason for doing the transition is, again, the same old people, NICE, the National Institute of Clinical Excellence, which is a body in UK, which tells the clinician what is the best practice, came with an idea about 4 years ago, roughly, and said the best practice is for complex neurological disability patients, it is best to have a transition of the care. A transition means they are still under the pediatricians, but then they slowly go over to the adults, and then they become adult patients. Now, the problem with that is the NICE is very good. It has a team of experts who give them advice, but NICE doesn't give money. It only gives advice. And we all know in life, advice is easy. You can get advice from anybody, like I'm doing. But money isn't. So when we had these guidelines to follow, we in our hospital decided to do a transition clinic, which is a virtual clinic, which kind of gives a full spectrum of expertise to the patient. And we discuss our patients once in 3 months. And you've got pediatricians, pediatric neurologists, the pediatric rehabilitation specialist, myself as an adult rehabilitation practitioner. You've got specialist nurses, you've got learning disability nurses, you've got physiotherapists, and we all do a call together and discuss a number of patients. We have now decided to discuss only 12 in a day. We used to discuss more. The idea of discussion is we discuss the diagnosis, we discuss the current functioning, we discuss the current needs, and then we transition them to the adult side. When they become adult, the whole spectrum of services is different. When they are under the pediatrics, it's the pediatrician who's in charge of the patient. The pediatrician is the one who will do everything for the patient, including the diagnosis of any acute problem, treatment of the acute problem, and even rehabilitation of the acute problem. But when they become adult, they go into the whole wide world where the disabled population lives in the community. And I'm talking more about the UK, where the health service is government funded, and then you don't get one umbrella or you don't get one clinician. You have a rehabilitation clinician, but for every specialty, you need somebody. For example, you need a PEC, you need a gastroenterologist. You have a problem with the hip, you need an orthopedic surgeon. You have a problem with the spine, you need a spinal surgeon. You need respiratory specialists, you need respiratory nurses, epilepsy nurses. It's a whole funda. But my job as a rehabilitation physician is to look at the patient and not the problem the patient has. If I have a problem, I go to the specialist. So as I said, transition is preparing them and getting them to the idea. And then when we transition the patient, we slot them into the While their streams are transitioning, we slot them into the adult clinic and we say, you will be now seen by an adult physician, and then gradually the pediatrics follow will stop. Now, I really envy the pediatricians in one way, and also the orthopedic surgeons, is that they are able to discharge the patient. You fix your hip, discharge. You fix your spine, you're discharged. You are now 18 years old, you are discharged. But as a rehabilitation physician, as a physiatrist, as a PMR, I very rarely discharge somebody or can discharge somebody. So we decided to come up with an idea of patient-induced follow-up, or we call as a PFU, where if the patient is able to call in a year's time and say, I still want to see you, and the patient gets seen. If it's a patient who does not have capacity, it does not have ability to think for himself or herself, then it's the carer or the parent will decide. So PFU is the new acronym. So what are the transition checklists we do? We look at the long-term health needs. We look at their lifestyles. We see whether they're independent. Most of them are not. Self-advocacy, no. We have to rely on the parents. Occasionally, we have people who are in employment, and one of the cases I will be discussing, we will come to that. And there is a lot of social and financial issues because disability is a long-term, and in parents looking after disabled children, finance is a big issue. So how we introduce them to the transition is the pediatrician will, in the previous consultation, tell the child's parents that your next appointment is going to be with the adult physician, and they will be looking at all the aspects of your care, future referrals, etc. And we will be now giving you one more appointment and discharging you back to the GP. The GP still remains the hub where the acute care is provided, but the rehabilitation side of things, for example, treatment of their rehabilitation needs, their pain, their spasticity, their wheelchair, their equipment, their education, their educational support, all those things then come to us. So in the United Kingdom, there is a provision called as a EHCP, which is a support of education for anybody who is diagnosed to have a learning disability. That cause may be anything. And the idea of the EHCP is to provide one-to-one support, extra classes, extra funding, so that the person then becomes adult and is able to do. And it works great when the person is just borderline able to do an independent living. The ability of that person to then transition from completely dependent to be independent is usually much more when they have an EHCP. Without EHCP, a lot of the borderline cases would go and become fully dependent. We look at their ability to independent living, look at their housing. Most of them are looked after by their parents. Look at their ability to do their own personal care. We look at their toileting and the other things such as financial support and further help. 90% of my patients are looked after by their mother mainly, and usually the clinic is accompanied by a mother rather than a father. Sometimes we have both. So again, just to emphasize what happens in the transitional clinic, we discuss topics relating to their general health. We discuss topics relating to their ongoing medical treatment, specific health needs to cover any specific diagnosis. They give a short summary, they involve the MDT, and the neurotransition MDT is typically about what is the next step for the patient. Education and employment is very important, and signposting to the resources in the community. A lot of the work in this country is done by the voluntary sector because health service is hampered because of the lack of resources. We have community physiotherapists, we have got learning disability physiotherapists, occupational therapists, we've got learning disability dedicated centers and some GPs with special interest. But as a rule, the health service is more designed for an acute problem and not designed more for a long-term care or anticipating the care. A big thing that happens when the children becomes adult is a consent, and whether to make any intervention, any surgical operation, maybe putting in a bed, and then this becomes an issue where the parents and other people then have to kind of look at whether the person is able to do the consent. Doing a consent and in adult is a separate subject in itself. I don't know how the pediatricians do it. A lot of the people who come to us from the complex have complex needs. They already have interventions done, such as a PEG, tracheostomy, or a suprapubic catheter. They already have been through all this. So we rarely get involved in this. So this is the team. The pediatrician, the rehabilitation consultant, the respiratory physician, the gastroenterologist, the learning disability nurse, dietitian, neurologist. This is by no means exhaustive, and we always invite people to come and join our team whenever that particular need of the person is identified. Again, as I said yesterday, it's not possible to have it under one roof. So we use the teams, we use the way of getting that message across to a number of other colleagues. And it's fascinating what you learn from your colleagues. 5 minutes. Thank you. So patients have complex needs, they may have disability, the pediatrician discusses the ongoing rehab needs, the patient is then discussing them transition clinic, and then patient becomes eligible to come to the adult rehabilitation clinic. So we run 2 types of specialist clinics in out of 3 types. We do an ITB clinic where ITB is monitored, intrathecal bacterial pump, spasticity where injection of botulinum toxin is given, and general rehabilitation. So patient, I looked at the audit, but I don't want to present my audit today. I will just mention that we are auditing this place, this service. For the last 4 years, we have seen over 75 referrals, and they keep adding up because unlike the pediatric age group, there is no ceiling for them. They just keep on adding. Talked about this again, so I'll skip that. So just to discuss 2 complex cases, mindful of the time. This is a young patient of 17 who has a sister of similar age with severe cerebral palsy, dystonia, encephalomalacia, microcephaly, epilepsy, spinal surgery done, gastrostomy, repeated chest infection, subluxative, discharged from orthopedics because they couldn't operate, constipation, previous admission to ICU, and so forth. So when these patients came and the parents were young, I discussed with them the future. And before I could go into the diagnosis and why it's just as I was mentioning yesterday in Dr. Ali's talk about not branding everybody as a CP, I found out that they were adopted. And the couple who adopted them were quite young, and it's quite a dedicated couple who took that responsibility. Unfortunately, the person who I'm mentioning got admitted with a severe sepsis. You can see how difficult it is to manage this patient. So we did ICU. Now, pediatric ICU, pediatric care is all under one umbrella. But when they became transition, the father called me and said, "Is there something I can do?" And I went to the ICU and said, "Just be aware this person can come to your ICU. This is the need. This is the plan." It was all discussed in the transition clinic. And, I don't know whether I was a prophetic, because in 6 months, She came with this severe sepsis. Unfortunately, didn't make it. Spent the time in ICU over 3 months and then sadly passed away. So family was grateful that the care was transitioned. Just quickly go to my second case. This is the same patient. Now, this is a 21-year-old. He was diagnosed as a CP with, he was a wheelchair user, came with a chronic hip pain, first to the GP, then a number of other services, and then the chronic hip pain in his right hip was never properly treated. The background is he had hip surgery in both the right and left hip. Not my expertise, but had instrumentation both sides. His right hip was constantly causing problem, and he had also had some X-ray done in another hospital, which showed that his right hip is quite dysplastic and abducted. So he came first to me in the spasticity clinic, and the question was, can I treat his spasticity? But because he was in such severe pain, he wouldn't allow examination. So I asked for orthopedic consultant who does the transition clinic, even though he's 21. He's working. He works at the university. He couldn't sit. He was so depressed before he came to me that he had tried overdose and suicide with the chronic pain. So I said to the orthopedic surgeon to have a look at his X-ray. This is the examination, not much to be obtained because of the severe pain. We had both sides, and sorry for the quality of the X-ray, but the right side was, the right prosthesis was broken, and the right hip was, this is after the surgery. So his spasticity and his pain improved after his surgery, and he has gone back to work. He is one of those CP patients who is able to converse with you. It's not dependent on his parents to give him any support. And this is how transition clinic works. If there was no new neuro transition, he would have just been discharged from the pain specialist, maybe the GP, maybe even the orthopedics. But working together, we bounce ideas, and I learned a lot from orthopedic colleague, but my orthopedic colleague also teaches a lot about me. And this was a good result of working together in this difficult age group. Thank you.